wonderful folks. Thank you. Add them. And if you've been around the block with us a couple times, we're glad you're back in the community together. As I said, Dr. Mimi Pattison is going to be speaking to us today. If you're not speaking, please do mute yourself. If we can see you, you can, turn your video on if you can. If not, we understand. Of course. If you're from University of Washington faculty, staff, or students, then you can register on this mobile text registration and sign in and receive your CME by texting this 10085 to the number that you see on the screen. And you should receive this response stating thank you, and we've recorded your attendance to University of Washington Project Echo Dementia. And if not, we're tracking your CME, so don't worry, and you'll receive that as well. But please make sure that you have your full name so that Sammy can provide the CME. Today, we don't have a formal case presentation, but I'm really confident that the content of the presentation will stimulate a wide-ranging discussion, and we welcome any questions, or perhaps you may have a mini vignette that you'd like to share that relates to the topic. And for subsequent sessions, don't hesitate to reach out to Sammy with her email or in the chat or on the website to share a case. There's a number of echoes, as you see here, through the University of Washington. There's one on traumatic brain injury, one through psychiatry and addiction. There's also a telehealth program. There's a fantastic resource for management of folks with complex pain and how to kind of manage their opioids and hopefully to taper them or minimize them or use other medical approaches. You see the hotline here, 1-844-520-PAIN. There's also a CME accredited case conference series. And then wonderful University of Washington psychiatry grand rounds with an archive, so you can watch all of those whenever you can and look at topics of interest. When there are case presentations, no PHI, we wouldn't want to inadvertently reveal anything about the person's identity. And please recall that all sessions are recorded and available on our website. And if you have time, do complete that 1-minute post-session survey. It's probably even less than a minute. It's very brief. And we look at it every week and we think about it together and we try to integrate the comments. And so as you see, there's CME through the University of Washington. We have nothing to disclose today, and if there is ever any relevant financial relationships, then they are really carefully mitigated. I think this is familiar to you all, our hub team. We've been here, but for those who haven't, see our smiling faces. And then, we've provided almost 1,500 instructional hours since the inception, June 2020. We are hoping to continue to grow throughout the state of Washington. We now have 70 sites and 187 providers. If you see this of value to you and your clinic, please do share as we continue to grow together. And without further ado, I would love to introduce Dr. Mimi Pattison, who has been a fantastic hub member since the beginning, and she has a really wonderful understanding of education in hospice and palliative care, and she's going to talk to us today about palliative care and hospice for persons living with dementia. Thank you so much, Mimi.
Thank you, Nancy, and thank you for this opportunity. Let me get set up here. I'm going to share my screen. Are we good? Okay, thank you. I see I brought a few supporting visitors with me today, so I just want to acknowledge them. Thank you. And Greg, hi, your first Echo Dementia. Great to have you here. So again, thank you for the invitation today to talk about palliative care and hospice for persons with dementia. I think there's an incredible opportunity in this sphere right now to maybe do things better. And this session is going to be very, very practical, and I trust that that's what will be useful to you going forward. And I would like it to be interactive. So if you have a question or something, unmute and speak up or raise your hand, and at one point in time, I'm going to ask you to put some things in the chat. So we have to have learning objectives, and those objectives include being able to define hospice and palliative care and list the differences between hospice and palliative care, specifically around dementia, and then to be able to dispel some common myths about hospice care, things I get called about all the time. And then kind of the big elephant in the room, if you will, that I'm going to address towards the end of my presentation is talking about the differences between dying with and dying from dementia. And that's going to be, I think, more of a challenge going forward. So I always like to talk about headlines. And headlines are a short statement. You all know what headlines are. You read newspapers or magazines that have headlines. And headline, for example, a headline is going to be when you go back to clinic this afternoon, somebody said, "What'd you talk about in Echo Dementia today?" The headlines are what you're going to say. So I just come up with a few of them here, and you may craft another one. So dementia is a terminal illness. Palliative care is everyone's job. I can't stress that enough. And good palliative care is preventive care, and particularly in the realm of dementia. And then to think more about dying with versus dying from dementia. So we didn't have a case today, so let's actually begin with the case. And this is a gentleman that we actually took care of on our service. So Mr. B. Mr. B is 89 years old with advanced dementia. And, you know, the reality is when you're in the hospital and you have dementia, you only have one kind of dementia, and advanced dementia. And that continues to be a challenge today. This gentleman truly did. He has had a history of hypertension and high cholesterol. He was hospitalized 3 weeks ago for a UTI, and he developed a stage 1 sacral ulcer. What do you think happened to him during the hospitalization that now predisposed him to a sacral ulcer? What happens to dementia patients when they end up in the hospital? Restraints? Common. So he went back to it was actually an adult family home where he'd lived for a number of years. But since he returned, he's sleeping more, communicating less, now coughing on thin liquids, and he developed fever and respiratory distress. So back to the hospital. And he is being treated for aspiration pneumonia. And this time, his daughter Paula has flown in, and she's at the bedside. And our job today is going to be figuring out how are we going to take care of Mr. B in talking with his family, Paula. So what are the big picture considerations here? Is this a gentleman who's admitted with community-acquired pneumonia and he's going to get better and go home? No, no. What is happening to Mr. B? Well, he has advanced dementia, and not an uncommon course from our perspective. So now I want to ask you the surprise question. Given what you've just been told about Mr. B, would you be surprised if he were to die in the next 6 months? Just shake your head. I'm seeing lots of no's. I wouldn't be surprised. So what are you going to do about that? What are you going to do about that if you wouldn't be surprised if he dies in the next 6 months? Trust me, please don't let the family be surprised either. Mm-hmm. He truly, I think, is at risk for dying in the next weeks or months. He's had a tremendous decline from now these 2 infections and now ongoing aspiration. You guys know what the future looks like. So his daughter Paula's at the bedside. What's she likely to be feeling during all of this? And when you go in to have the conversation with her, is it going to be a high intensity or low intensity and not much emotion? I think it's going to be high intensity. You're going to find out Paula is from the other side of the country, and since COVID hasn't seen her dad all that much. Talks to the adult family home, which she's very happy with, as they provide care for her dad. But there's high potential for feelings of grief. Obviously, he's getting sicker. What's happening? What's going on? Fear, and perhaps even shame that maybe she hasn't been as attentive. So you don't know what's waiting for you with Paula sitting there. So let's just start by looking at the spectrum of palliative care services. I like this diagram. It's colorful. It's a little bit different than what I've typically used in the past. And this is a spectrum of palliative care and hospice services for any chronic serious illness that progresses and ultimately becomes a terminal illness. So starting over here on the left, there is some screening, and we're good, aren't we? In the state of Washington, we're doing more screening than ever, right? And because of echo dementia and all the education that has come forward in the last 10 years. So there's the screening portion of this trajectory, and then at the time of diagnosis. And what is key here, you can see on this diagram, we talk about curative care. There's not curative care for dementia, we know that. There can be maybe some disease-altering therapy or life-prolonging therapy. We talk about it. But also way up here now, we're starting to address and introduce palliative care. And this really needs to be the model for all chronic illnesses, whether it's dementia, heart disease, or cancer. And then as the disease progresses, moving across the spectrum here, and there are fewer and fewer options for disease-modifying therapy, and then more and more palliative interventions are appropriate until kind of bam, we reach that physiologic wall where nothing else that we can do clinically is going to alter the course, and the patient is going to go on and die in some probably short time frame. And then at the time of death, and after that, bereavement is such an important part of hospice. And most hospice programs serve their community. And you don't necessarily have to have a loved one on hospice to benefit from bereavement. And I bring that up today just to make sure everybody knows that, because it's so important. Bereavement and grief are not something that we typically do well in our culture. Anyway, so this is the spectrum of services that can and should be available to a person across the course of any serious illness. And today, obviously, we're talking about hospice. So what is hospice care? Just a basic definition. I'm sure most of you know that. It's care for persons in the last 6 months of living. So how do you know? How do you know? Do they come marked with this, or how do you know? And what if you're wrong and you tell somebody that they're at risk for dying? And risk for dying is how we like to talk in our world, because that's what we know. We don't make threats and we don't make promises. I'm concerned your dad is at risk for dying over the next few months. And that's easier to say, and it's easier for patients to hear, and it's the truth. So you don't have to worry about being wrong if you have a really good relationship with a patient and family. And how do you know? We're going to talk a little bit more about that too. So again, back to the surprise question. It is a great screening question for patients with dementia and for others. So would I be surprised if this patient dies in the next 6 months? And if the answer to that is no, I certainly encourage you then to reach out to your local hospice and make the referral. It is then the obligation of the hospice to certify that in their best judgment, the patient is most likely to die in the next 6 months if the disease takes its usual course. Well, show me somebody that takes their usual course, right, Greg? Yeah, anyway, that's what the rules say. So, and then that care is going to include the whole hospice team, which is a nurse, social worker, CNA, comfort therapies, all medications and equipment, bereavement services, and just all kinds of supportive services. And the majority of care is in the home. We have about 350 patients on our service today, and the majority of them are in homes or in a long-term care facility, assisted living, adult family home, where they call home. So hospice care is mostly done where the person is living, and we try to maintain that. Hospice care is also considered by some as an insurance benefit. It is. And it was for the commercial payers, it's most often modeled after the Medicare benefit. That 6-month time frame and everything is all inclusive, and there may be some exceptions. And we all know that Medicare doesn't pay for room and board under any circumstances. Patients and families don't understand that, and that can be a real difficult point in time when they begin to understand that there could be some cost, particularly if they're unable to keep their loved one at home. So what is palliative care? Well, palliative care is specialized medical care for people living with a serious illness. And kind of the operative word in that first bullet is living. So palliative care doesn't have anything to do with prognosis. It's for persons with a serious illness, who have a progressive serious illness, who have an unmet need. We say an unmet need. And the goal is to provide relief from symptoms and stress of the illness, all the time trying to improve quality of life for both the patient and the family. And again, the referral to palliative care, particularly specialized palliative care, because I've already told you palliative care is everybody's job, and I'm talking to every single one of you. For generalist palliative care. But once you've referred to a specialist, then it's specialized palliative care, and it's based on a need, an unmet need. And that often is the need just to have more conversation and understand and plan for the future. Or it may be symptom management, pain, otherwise dementia, agitation. So palliative care is appropriate at any age and any stage in a serious illness, and can be provided concurrently with curative care or disease-modifying therapy. So palliative care is really focused more on living. Hospice is also focused on living while preparing for dying. So there's that 6-month time frame. So hospice is linked to prognosis. Palliative care is linked to an unmet need. And for some people, it really turns on a light when we say all of hospice is palliative, focused on comfort and quality. All of palliative care is not hospice. So there really is a distinction between the two. And I like this diagram because it shows how they overlap. The supportive palliative care, and then the overlap, the things that are in common: optimizing comfort, reducing stress, relieving symptoms, and providing that emotional and spiritual support, that whole person care that we all love and that patients want and need. And palliative care is often paid by insurance. There's often a copay. That's been a barrier at times. It can be given at any stage of the illness. Early on, it's more about directives and planning. Later in the course of the diseases, it's more about symptom management. And more palliative care today occurs in hospitals. There is some home-based palliative care. You have to know what's available in your community, and I encourage you to make those connections before you really need them, so that you can call these folks and ask, what do you think about this? Or is this person ready for hospice? And again, hospice care, it's an insurance benefit. Patient has to have a prognosis of 6 months or less. They can't be utilizing curative treatment, and hospice care typically occurs where the person is living. So what are the Medicare criteria? We all know that Medicare has lots of rules, like tens of thousands of pages of rules. Greg, you're laughing. It's not funny. And we have conditions of participation that we live and die under or whatever. And so we have to know the rules. And the rules haven't changed for a long time. What changes over time, though, is interpretation, and how they interpret something on the East Coast and on the West Coast is a little bit different. And then when you get those people together in the same room at a national conference, all kinds of things happen. Anyway, so Medicare has criteria for a number, lots of chronic illnesses. But these are the criteria for a person who, as their primary terminal illness, it is a form of dementia, Alzheimer's or other. So on the FAST scale, they have to be 7 or higher, and that's what we use. They're dependent for all ADLs and probably incontinent and have limited verbalization. So a FAST 7 or higher, and one of the following medical complications, if you will, in the last year, either an aspiration, pyelonephritis, sepsis, multiple decubes that are advanced, recurrent fever after antibiotics, or inability to maintain sufficient caloric intake so that there's weight loss, or a serum albumin of 2.5. Now, this all sounds well and good. Unfortunately, our patients don't come labeled like this or boxed with this. They come with maybe one or two of these things and some heart failure and an ejection fraction that's 30% and all kinds of things. And we have to do our best to figure out, are they hospice eligible or not? And a lot of it, it's not fitting the absolute criteria, but it's the big picture and it's the narrative story that we write. And it's our legal responsibility to certify that that person is terminally ill. You out there in primary care and in other settings have the obligation to think about it and to ask yourself that surprise question and to reach out to your local hospice and find out. So again, and even NHPCO uses the surprise question. Would you be surprised if this person dies in the next 6 months? So when we look at our community, and interestingly enough, it's a little bit embarrassing to say, since I've been involved in hospice care for decades in the state of Washington, that hospice utilization is dropping. And at one time, we were at a penetration rate of around 48 to 49%. It's higher down in Florida, where there's a hospice on every corner, and it's easy. And we're a certificate of need state. Does that influence that? I'm not sure. Anyway, for some reason, COVID and a lot of other reasons, hospice utilization has fallen off in the last couple of years. And I was really surprised to hear that in our state, we are down to about 40%. So 40% of people who die receive, and this is Medicare data, have received hospice. And 90% of us die with some predictability. So why do only half of us ever even get referred to hospice? Well, there's lots of barriers out there. And I just want to address a few today and hopefully maybe break some down. Late referrals, 30% of our patients who are referred to us die within a week. Folks, that is not hospice care. That is not hospice care. That's emergency end-of-life care. It's not hospice care. They haven't even met the team. They haven't even met the team. And it often leaves a lot of unmet expectations. Because usually we walk into a situation where the family has been told hospice will do everything. Well, if hospice has 24 hours, they don't do much. And so expectations are not met. And you know, and it's just wrong. I just think it's wrong. So we need to think about referring earlier. And that's why we need to think about screening questions. And if you're wrong, that's okay. And we can admit patients to hospice who we believe, based on what's happening right now, are likely to die in the next 6 months. There are many patients who we've had to discharge because they get better. We take away a lot of chemicals. sorry, Trang, we take away some of those drugs you love and help us with, thank you. And really provide that holistic care and support for the family, and stress goes away, and lo and behold, they get better. And there is nothing worse than discharging a person from hospice. It's much more difficult than bringing them on and having those conversations. And in dementia, 10 years ago, very few dementia patients got hospice at all, because we didn't know how to take care of them. We didn't know when we should bring them on or anything. So there's been more interest, and more hospices stepped up, and we were one of those hospices. So lo and behold, then we found it really difficult when they would start, these patients would start getting better. So they would have long lengths of stay, or we would discharge them, and Medicare began to look at that. Oh my gosh. And the reality is we have to deal with the results of the fraud and abuse that's out there, just in general, but particularly in the hospice world. And some of you may have seen some of the documentaries on television. So dementia patients, and this has been written up nationally, in the last few years, fewer dementia patients than ever are getting hospice care. And it's just really profoundly disappointing to hear that. These families have been going through this illness for 8 to 10 years, right? Or many years anyway, and they desperately need support. And when it comes time and we may have to discharge these patients, we often will discharge them to the ER because they're at home. There's very few doctors that do home visits, and it's hard to find them care. And it really causes a great deal of moral distress. That's a whole subject for another discussion. Other barriers, inexperience in hospice referral. Do you know your local hospice folks? Can you reach out to them? Can you get to know them so that you know they're there when you need them? Discomfort with a conversation, probably one of the most common. My patient's not ready. When I hear a clinician say that, I say, I don't think you're ready to have that conversation. That often is the case. That often is the case. And then fear of audits. And this is over the long length of stay. And I hope that's going to get better. And then estimating life expectancy can be difficult. It really can be. We've all seen dementia patients with aspiration pneumonia who look very much like they're not going to live through the night. And we come in the next morning and they're sitting up eating breakfast. And I say that with all sincerity because it happens. And another barrier, I listed here family. And I don't have culture because Dr. Diane Farron at Madigan did a lot of research in culture when she was living in Hawaii. And she didn't really come up with anything very useful. The most useful thing she came up with is, if you ever think about mentioning culture to a family, use the word family instead of culture. We have multiple generations of families from one culture, and all 3 generations may do things differently. So we always say, how are things done in your family? Yeah, and we don't get ourselves in trouble as much by doing that. So lots of barriers to hospice. Think about those. What are some of those maybe in your world that you can help with? So I couldn't help but throw in our house model of communication here. I hope you all have some sort of template or some method that you follow when having these highly emotional, intense conversations with families, particularly in advanced dementia when it comes to issues like around tube feeding and all of that. So this is our house model, and this is just a PDF of the house model card that we give out. And we build the house with the family. It's not with the patient who has advanced dementia and can't participate. You know, we establish relationship and then always go to the patient story first. Always go to the patient story first. After you found that, then you ask permission to give the medical recommendation and fill in any gaps that you may have. And then balanced between the patient story and the medical story is that medical recommendation. What do you suggest for ongoing care? Not what do you want? My recommendation, based on what you've told me, is so important to you today. I recommend we continue with comfort-focused care, allow dying to happen naturally. I wouldn't recommend we interfere with CPR, or whether you're going to recommend against antibiotics or whatever. Anyway, have a model of communication that you use that you're really comfortable with, and that moves the conversation along. This model we love. There are a number of systems in our country that use it. It is incredibly time efficient, incredibly time efficient. And on the back of our card are these magic ways and words that work. So what about palliative care along that course of someone with dementia? So wondering and worried, those with mild cognitive impairment or early stage dementia. What are some sort of palliative interventions that we might think of at that time? Well, as we do think about that, we know what an emotional time this is. It may be they've just been given the diagnosis or they're seeing more change. So it's always going to be high intensity emotionally. And we know that if we respond to the emotion that the family is showing us, and we acknowledge that, give that time to clear, we know that they will think we are more competent, because we know that. And always asking before we tell, ask before you tell is our number one tool in communication. And then asking permission. Help me understand how much information you'd like to have from me today. We don't just go giving information because we know what's out there in the course of this illness, right? And it's not pretty. And so we need to ask, how much information do you want? And they will tell you. And the most important palliative intervention, and it should not be in the palliative bucket, unfortunately, it still is often today, is appointing a durable power of attorney at the time of diagnosis of dementia, if the person can still make that decision. That is the most important. A trusted person who will speak for you, not for them, not for what they want for you, but will speak for you in the event that they are no longer able to speak for themselves. So when we think about back to that diagram, the spectrum of palliative care and hospice services across the disease spectrum, way back at the time of diagnosis, that's when that conversation has to happen about the DPOA. That's not when you have the tube feeding conversation. It's not. That comes much later. But appointing that person and then recording it also. And it's the conversation that's important. So really encouraging directives, So what about mid-stage dementia? Things are worsening and we may be seeing difficulty with agitation and understand that and not understand it's part of the disease process. May start to see some swallowing difficulties, and that's scary. And pain may be an issue, an inability to express pain. And we need to understand how to assess pain, how to treat pain, and to evaluate its effectiveness. And during this time, our caregivers are probably experiencing some burnout, at least fatigue, and need the support that we can give them. And then also preparing for the transition. So late stage dementia are when we really see the challenges, when we often have to talk about artificial feeding, recurrent hospitalization, infections, and now today, treatment for other conditions. The first dementia patients that we brought onto hospice 10 years ago pretty much had dementia. They were really healthy otherwise. They did not have cancer. They did not have heart disease. Many of them had hypertension, and it was well controlled. But now, what about the persons with dementia that develop a cancer or develop heart disease or something else that needs an intervention, that has burden to it, that has side effects? How do we manage that? And I think that's where we really need to take the conversation. And also in late stage dementia, when will we consider hospice care? And again, back to the surprise question. Well, I talked about some myths. Let's bust some myths, okay? out there about hospice. First of all, you can't have hospice care longer than 6 months, or you come on hospice, you cannot live longer than 6 months. The answer to that is no, as long as you meet criteria and qualify and continue to show decline, the hospice team can document that you are still appropriate. And we have had patients on for 2 years. We've had patients on for a year. We're scared to death about that today and we're audited all the time, just regularly. And we know that that's going on in our community and across the state and across the country now, just random audits. That's okay. But there is a 6-month guideline. It's not written in stone. It's not a line in the sand. What about, how many of you have heard that the person has to stop all their medicines when they go on hospice? They don't get medicine except comfort. And that's not true. When you think of heart failure, everything those folks do is palliative, right? They think it's heart failure care, and it is. And I have great respect for that. But it really is palliative. It's focusing on symptoms, it's managing symptoms. Those medicines are important when the patient comes on hospice, and we keep those going. The medications that will be useful at this time. So meds are something that we always talk about. And we always turn to our pharmacists to help us too. They're a critical part of our team. What about, and Karen, the person can no longer see their usual doctors. That is not true. Billing is different. And every hospice, I think, approaches this differently, as Karen has educated me. And once the person, when they sign on to the hospice benefit, they give up their Medicare Part A for that condition. So all of the care that is given, the hospice is responsible for, so all of the cost. And usually that's directed by the attending. Well, some people still want to see their brain and memory wellness center clinician. They want to see their cardiologist. They want to see their oncologist. And we always talk about that. And when that happens, the specialists have to bill us. And then we in turn bill Medicare. Or occasionally we will say we will just pay for it just because it's an added burden. But the patients that are on hospice can continue to see their regular doctors and often need to. They're a critical part of their management, particularly when it's complicated behaviors. And they're the ones that are really directing the medications. So I hope that clarifies that. Every hospice approaches it a little bit differently. It's how the billing is done, and it's an added step. Greg, you have your hand up.
Just a quick question on that, Mimi. Do they need to have a contract with the doctor, or can they just see the doctor and the doctor submits the bill to hospice?
Some people are saying they need a contract. I can't imagine us doing that with all of the people in our community that our patients go see. No, we have to have contracts with facilities and all of that, but we are not requiring that at this time. I don't know that that's going to be coming or not, but a good question. Yeah. More contracts, right? More fun, more legal fun, more work for the attorneys. Yeah. Anyway, I'll move on. Hospice does not allow hospitalizations. We don't use IV fluids and we don't give antibiotics. All wrong. We give care that is appropriate and is going to focus on quality of life and comfort. And occasionally, care can be given in the home any longer. We happen to have a hospice unit that we can bring people into. Very limited number of beds, and it's geographically isolated from 90% of the community that we serve. So occasionally there is a need for a hospitalization. And and sometimes we end up paying for that. If the patient chooses to continue with some type of aggressive care, then they have the option to revoke the hospice benefit. That gets complicated. And this is a big one. I'm not going to go on hospice because I'm not ready to die. As if it's an option, and it's not. Dying is coming. We can't stop that. We can influence how it's going to be. Any other questions or comments about these myths? Hope this is helpful. So we always like to say it's our professional obligation to make visible the invisible. When a person is diagnosed with dementia or a dementia-like illness, they don't know, most people don't know what the future holds. They may have had a grandparent or someone or a friend who's had some memory problems, but they don't know what you know. And at some point in time, they need to. And we need to make visible for them what is invisible to them. Okay? So what information do they need? Always by asking, how much information do you want? And when we have these conversations, they're high intensity. We always ask before we tell, what have you heard? What do you want to know from me? We always respond to the emotion and talk in headlines, like I talked about. Headlines are 15 words or less. That's what you're going to remember when somebody talks to you, and that's what they're going to tell their loved one when they leave your clinic. So we speak in headlines. Once you're past 15 words, memory falls off, ability to retain any additional information, and their attention span drops off. So headlines are really crucial in good communication. And then using teach back. And again, palliative care is preventive care. We don't like surprises because they cause regrets. So we think the more people know, the better prepared they are. It's not going to be easy, but it's not going to be as hard. And when people know what they're dealing with, and I bet all of you can think of a situation in your own life where once you got some terrible news, some very serious news. Once you understood it better and knew what you're most likely in for, then you have that reality to deal with. And that is much simpler than fear of the unknown and your imagination is running wild. So we like to think of a lot of the care that we do in planning and letting families know what might lie ahead. That is all good preventive care. So make visible the invisible. So let's go back to Mr. B. And when we think about Mr. B's ongoing care, there are lots of questions that we have. You know, are we going to continue to treat infections? What about the next one? He's much weaker now, bedbound. Can he go back to where he was living? All of those questions come up. But the biggest question is probably going to be around tube feeding, right? Would everybody agree? So I just want to spend a little bit of time talking about that. What are the options that we can consider for his ongoing care and to be thinking about in our mind? Well, we still see people being sent to the hospital to get a tube put in when the family calls the doctor and says, no longer able to swallow or choking. We'll go get a tube feeding put in. So is that a viable option? We actually know, and it's been well documented in the medical literature for more than a decade, closer to 2 actually, that artificial feeding via a PEG in someone with advanced dementia does not positively impact their weight or pressure ulcers. It may actually increase morbidity as they have more secretions, difficulty handling those secretions, and more aspiration. And it doesn't improve survival as compared to people that are carefully hand-fed. What about a time-limited trial? Some families just can't go there yet. They just can't go with comfort feedings. So we have to negotiate that. And with an outcome that we can measure. So we know, is it working? Is it working? And then comfort feedings, one-to-one hand feeding, often an order in the chart every 4 hours while awake, and then managing symptoms, engaging hospice, and allow dying to happen naturally. What about TPN? TPN is not an option. We still get asked occasionally, IVs or TPN, but that's a short-term intervention to foster recovery from something else that's going on. In this circumstance, it is not a viable option. So when we think about what concerns families have around not being able to eat and what concerns we have around potentially artificial nutrition, hydration, actually the list is quite different and there's not a whole lot of overlap. Families worry about choking, weight loss, and what's the most common concern families have? Starving to death, right? I can't let my loved one starve to death. And from our perspective, we're concerned about aspiration, about other complications, and then those restraints that lead to more and more problems. So now just to digress a little bit, I want you all to put in the chat, please, 2 reasons why you eat. Two reasons why you eat. Keep body fueled, satisfy hunger, enjoyment, hunger, pleasure, enjoyment, pleasure, nutrition, enjoyment, sustenance, and enjoyment. Taste, company. Okay. Community, love that. Oh, survival. So we have a survivalist in the group. So when you think about why we eat and how we're going to take care of Mr. B, does that kind of make a difference? So there are lots of reasons why we eat. So, and we want those reasons to continue to be present for Mr. B, right? You know, and really food is love. It's our way of showing love. And is tube feeding food? Is it showing love? Does it have taste? It has an awful taste. Smell, texture, social connection, that one-on-one connection has some nutritional value. But we need to think about why we eat and what are we going to recommend for Mr. B in this condition of advanced dementia. So when we think about these options, again, what's really the best match for him? Is it to give him artificial feeding, a trial, or is it comfort feedings? Well, first of all, we need to know a little more because we still need to have that conversation with Paula. And again, just a review in the literature, the American Academy of Hospice and Palliative Medicine has a statement and a recommendation mostly against feeding tubes with advanced dementia, and to offer oral assisted feedings, one-on-one feeding, comfort feeding, whatever you want to call it. And it's also part of the Choosing Wisely program recommendations. So we're going to talk with Paula and we're going to kind of build that house with Paula. And so let's think about building a relationship. We go in and introduce ourselves and we find out from Paula. She is an only child. She lives in New Jersey. And she talks regularly to the staff who care for her father. She's not really sure what's going on. She knows a little bit about advanced dementia. When he was first diagnosed, she said, I read some things and then I just didn't want to read that. So I just kind of really don't understand a lot now. So here we go. We are going to have to make visible the invisible for Paula. So we've asked Paula how she's doing. She just flew in on red eye. She's tired. She's jet lagged. And she finds her father, who now doesn't respond to her and is in the hospital for the 2nd time with an infection. And you also find out she's an only child. So the burden is on her. This is Mr. B's family that you're dealing with. So now we're going to move on to his story, and we need to know more about Mr. B. Well, Paula tells us she's always been really close to her father, particularly since her mom died. And he was always big in the family with his traditions around food. He was kind of a foodie. And so big family gatherings with food were a really important part of their family traditions. He was also a master builder. He was widowed 4 years ago. Quiet, not much of a talker. When you ask Paula if they ever had a conversation about the future and what he might want in healthcare if something serious were to happen, no, he never talked about that. Never talked about that. You find out he never talked about healthcare directives and avoided doctors at all costs. So here we are, Mr. B's in the hospital again, receiving antibiotics, and he is not his decision maker. And does that make you worry? Oh my gosh, have we crossed the line with Mr. B? Anybody have any thoughts about that? There's still more we need to know. So you use your best skill, and you know that if you say, tell me more, or anything else, Paula, that you might get a nugget that is really important. So you do that. Paula, is there anything else you can think of? So you're going kind of one more level down in that conversation. And what does Paula tell you? You know, I now remember that Dad said one time, if I can't pound a nail, let me go. What does that tell you about what you should offer Paula as the appropriate care for her father? One thing I would want to know is, oh, Paula, can you please tell me, when was the last time your dad pounded a nail? Anybody else want to know that? It was a year and a half ago. So what have we done to Mr. B in that year and a half? Well, we've hospitalized him a couple times. Paula told you he went kicking and screaming to the adult family home, but he's settled in nicely and he has buddies there and he enjoys the meals and the socialization and all of that. So we're trying to craft an ongoing plan of care for Mr. B as he comes towards the end of life. So we have found out the patient's story. We found out a lot in a very short period of time because of the questions we asked. So now on to the medical story. That's where we fill in the knowledge gap that we have determined in listening to Paula and what she knows about dementia. We avoid using the word understand because that's kind of a test. We ask patients and families, what have you heard? What have you been told? So we know that this is really typical in end-stage dementia, this course that he's on, and that he is at risk for dying. There's that phrase, risk for dying in the next weeks to months. And we need to make that visible for Paula. We need to share that information with her. And we do that as a medical recommendation. Our medical recommendation in that house model balances the patient story with the medical story. So our recommendation for Mr. B is going to be ongoing care in the adult family home with hospice and with comfort feedings. And giving her more information about comfort feedings. What might that look like? Well, then you find out his favorite food is ice cream. So he can have ice cream 3 times a day or whatever he wants in his favorite flavors with comfort feeding. So all the components of why we eat, we can still provide with one-to-one comfort feeding. And then you ask Paula if she agrees. If she agrees. And if she doesn't agree, then there's more discussion to happen. And then you move on with a collaborative decision-making. So Mr. B is a gentleman with a real typical story, repeated hospitalizations, repeated infections. And we finally had the conversation with the family. Tell me what's important to you so I can make a medical recommendation. We wouldn't be surprised. So our recommendation is hospice care. And Paula and the caregivers at the adult family home will get great support from the hospice team as they care for Mr. B through the end of his life. Any questions about any of that?
Mimi, this may be more of a
Right.
comment than a question. As we talk about oral assisted feeding, one thing I have found remarkably helpful for patients who are being hospitalized, I suppose the outpatient setting it could apply as well, is we've developed a good relationship with our speech and language pathologists.
Mm-hmm.
Early on, therapists were often signing off on our comfort care patients, and I kind of wondered why. And I talked to some of them, and they said, well, our focus is rehab oriented. And when the treatment goals are no longer geared towards rehab, we're not sure that we have a role. And so our palliative care team has done a lot of work with SLP, PT, and OT to really look at what are the therapist roles in comfort care patients to the extent our hospice agency now actually employs an OT, and it's not for a rehab focus. So just to say, establishing those relationships across disciplines can be really beneficial for opening up patient care opportunities.
Absolutely. Thank you, Greg. Yeah. So I want to spend our last few minutes talking a little bit about this article editorial that I found while I was preparing for this presentation. And it's entitled Dying with Dementia, Under-Recognized and Stigmatized. And it was published in the Journal of the American Geriatric Society in 2019. And it's a page and a half long. And if you actually just Google that citation, it'll pop up. And I think it's worth reading because it really did stimulate a lot of thought in me. And I will say, they just talk about how the fact that dementia is a terminal illness is under-recognized. The authors of this editorial did not know what's going on in the state of Washington. And I am very proud to be a part of what's going on in the state of Washington, because we are here today talking about dying with dementia or dying from dementia. And we are doing what we need to do to begin to educate. We have a ways to go. But we are on that path. The reality is the elephant in the room is still death, often around dementia. 30% of people today who die, and this is Medicare data, have dementia as their primary cause of death or as a contributing illness. 1 in 3. 1 in 3. And look at the dollar cost to the family. $61,000 of out-of-pocket expense for someone with a diagnosis of dementia, twice as much as other conditions. There's a high symptom burden. There's frequent hospitalizations. There's invasive procedures and brink of death referrals versus the long length of stay. And how can we come to kind of that comfortable middle? So this article really addresses that. And these people didn't know all of the wonderful things that the state of Washington is doing. So I just had to call that out. But I really like this diagram. It shows the spectrum of dementia across time. And at the bottom, kind of what is going on in their medical care. And again, starting with primary care and screening. Then as a person develops mild dementia, they may see a neurologist, but they're still seeing a primary care and a neurologist. So when we talk about having the directive discussion, whose responsibility is that? I don't have the answer to that today. And we hear that in the hospital. Why didn't these people in primary care have this conversation with this person before they got this sick and in the hospital? And no, now's the time to do it while they're in the hospital. So we have to think of when is the right time and whose responsibility? Well, I go back to the premise that palliative care, i.e. talking about directive, is everybody's job. And I'm talking everybody. So on progressing on along the spectrum of the illness to moderate to severe dementia, you may involve specialty palliative care or special geriatric care be added to the team. And again, we need to know who's going to be responsible for doing all of this, making the invisible visible. And finally, the advanced dementia that we've talked about today with Mr. B, that's pretty straightforward. So Mr. B is dying from dementia. When someone with mild cognitive impairment develops cancer and dies from cancer, they die with mild cognitive impairment. If they have mild dementia, with mild dementia. And this is where I think it's a little bit scary. When people have moderate or severe dementia, they're awake and talking. It doesn't make a lot of sense, and they're not decisional, and they develop a cancer. And who makes the decision about ongoing cancer treatment care? We have seen cases where families have decided. And I was sharing with Nancy, I actually absolutely had this consultation this morning at 7 o'clock when I arrived in my office. And it was a case I'd love to talk about today. Can't do it. Maybe at some point we can. But a person with moderate dementia who now has a diagnosis and decisions need to be made about medications that are going to cause her side effects and things. And who's going to make those decisions? So dying with some form of dementia versus dying from dementia. I think we're getting better, although CMS continues to challenge us with their audits and length of stay and all of that. And there also is our efforts out there to attempt to expand the Medicare benefit to a year. The Medicare benefit fits cancer patients well. Well, less than a third of our patients are cancer patients today, and the benefit really hasn't changed. As I said, interpretation does. So dying from a condition with dementia, I think, is a really big challenge today, and we need to have that conversation. Dying from dementia is really pretty straightforward. The tube feeding piece is not. It really is not. Food for thought? A lot of food for thought, right? So now I have a case to end with. 76-year-old female presents to you in primary care with weight loss and a chronic cough. Her chest x-ray shows a spiculated mass in her right upper lobe. Her other medical diagnoses include hypertension, COPD, and dementia, probably Alzheimer's type, and she's a fast 6. Needs help with all ADLs, and she is incontinent of urine. Now what? Now what? So I told you about the headlines that I think are important. You all remember them? Well, just in case you don't, I have them here again. So dementia is a terminal illness. Palliative care is everybody's job. Everybody get that? It really, yeah. Palliative care is preventive care. Palliative care is preventive care. So the operational headline in this case is palliative care is preventive care. And I have really good news for you, because you have already started the conversation with this woman and her family long ago in the care planning that you did. Can we talk about the future? What if something else were to come up? That's something we should talk about at some time, and what would be important to you. So good for you, all of you clinicians out there. You have already had that conversation with the family. And you have prevented maybe even a crisis or a very difficult decision by having that conversation and documenting it. So I want to end with dying can be successful. We often don't think about that. Dying can be successful, and it should be. It should be. It's our obligation to make sure that that happens. As always, know your headlines. And Maya Angelou, my favorite, tells us, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So thinking about feelings, making our patients make sure they're heard and that they feel felt all along the way so that they're getting the best care possible all along the entire course of their dementia diagnosis through death, and the family is supported and the family gets good bereavement care. So thank you for listening. I hope I've generated some questions or considerations, or maybe we should have a second session and talk more about that. We need to have a conversation as
Mimi,
our patients are living longer.
thank you so much. I mean, this is such a complex topic, and you bring so much wisdom. And even just in that headline of, helping people to feel felt at every step along the way, and that palliative care is preventive. Wow. So I have a question, which I will hold and open it up to the community to see if there are any questions from you all. Yes, Karen.
Hi, everybody. I just like to, it's not really a question, but just a personal experience as a caregiver of someone who ended up with advanced dementia and died of dementia. My husband had 0 other comorbidities at age 71. And, but so we had a palliative care consult when he was in moderate dementia. And it was a nice long interview. And then they said, what can we do for you? What do you need from us? And one thing I really wanted, having been in lots of support groups and hearing lots of horror stories about ER visits and ICU visits and the interventions that were done to people's loved ones when they didn't want that on their advance directive, and when the person with the power of attorney was standing there saying, no, we don't want intubation, we don't want antibiotics, this person, my loved one, doesn't want X, Y, and Z. And either getting talked into it or bullied into it or being done behind their back. So one person in a support group, she was in ICU with her mother, very advanced dementia, broke a hip, and sat there for 3 days and said, no, she doesn't want surgery. She just wants to go out, keep her comfortable. And then after day 3, this person went home to take a shower and change clothes and came back. Where's my mom? Oh, she's in the OR. The orthopedic surgeon came in and consented her to surgery, and she was in the OR, and then she ended up dying in the ICU the next day. So that kind of stuff that was just something that was 6 months ago. So when I would talk to palliative care, I said, what I need somebody on my team. So if I'm in the ER, I'm in the ICU with my husband for whatever reason, he wasn't on hospice at that point. I need somebody, I need a physician or a respected healthcare provider. And I'm a nurse practitioner. I can speak medicalese, but being the wife and so forth, I didn't want to get in that nightmare scenario. And so that person promised me, yes, you call us 24/7. There's always somebody on call. We'll get on the phone with ER doc or whatever surgeon. And that never had to happen, but it really gave me comfort to know that I had somebody on my team who could speak the same language and know what it was that my husband had wanted, what I wanted. And then when he got admitted, when he ended up in severe dementia, and he was in geropsych for 7 weeks, and palliative care at that hospital came, and they basically said the same thing. So the same headline from both of them: what can we do for you, and how? knowing some of the things that can happen in the medical system, how can we support you for your end of life goals? And so he said the same thing, and he gave me his card and he said, here's my personal cell phone number. Maybe because we were both nurse practitioners, he sort of did this special thing for me. He said, put this in your back pocket. If your husband ends up in the ER, you call me immediately and we'll make sure he doesn't end up in this intervention, surgery, intubation nightmare that you didn't want. And so again, that might have been a little bit special for us, but it was super comforting and gave me a sense of control to have that successful death. Because him dying intubated with a new hip in his side that he didn't want, dying in the hospital was not what he wanted. So just another plug for palliative care and having them be part of the team and really emphasizing to the caregiver, you know, this person's there to help you and help you be the right POA for this affected person.
It needs to be the standard, you know, it need for everyone across the board. Everybody's really quiet.
Anybody want to put their question or comment in the chat and I can read it? I want to recognize, and I know we're all feeling this, greatly appreciate your presentation. Thanks, JT.
Thank you.
This is Karen. I'll bring up another issue that actually came up recently in an Alzheimer's support group where we were talking about advanced directives and so forth. And it's actually a specific Alzheimer's support groups for those of us who are healthcare providers and we're caring for a loved one, parent or spouse with dementia. And it was interesting, the range of opinions. So the person who has dementia has filled out an advanced directive saying they don't want tube feeding, they don't want intubation, they don't want CPR, no antibiotics, blah, blah, blah. And so that's all done either before they got dementia or hopefully when still mild. And then the funny thing was, to me, was some of the people in the support group said, well, when their dementia gets advanced, they can change their mind. So imagine someone with severe dementia and a healthcare provider comes in and says, do you want a feeding tube? And they're like, sure. They don't. So the POA, the loved one at the bedside is like, no, he didn't want that. They didn't want that. And then, but they're saying they want it now. They're getting enjoyment out of life. And, you know, so and it was interesting. There was a real variety of opinion about that. So any advice, Mimi?
That's the conversation we have to have, Karen. You know, about more of this. And, you know, can families consent to invasive cardiac procedures and chemotherapy?
Karen, one of my other roles is the lead ethics consultant at St. Peter Hospital in Olympia. And these are the sorts of cases that we often get called in on. A lot of it comes down to the patient's decisional capacity. So assessing, do they understand their health condition? I know Mimi said not to use the word understand, but maybe in this setting we need to. Can they articulate what the recommended treatments are, what the implications for accepting or declining the treatments, and so on? And then if they do not have decisional capacity, their loved one really does then take over as their voice. The bigger thing we often face is the person who has the do not resuscitate pulse that then the loved one at that moment wants to reinstitute full code status. And there are times that's exactly an appropriate thing to do. I've seen cases where that reversal was really probably clinically a very appropriate decision. But as Mimi said, that conversation is so crucial. And making sure that the person has adequate decisional capacity to be weighing in on it. We had one recently where the guy lost his decisional capacity, had not designated anybody. His spouse was becoming increasingly debilitated, didn't want that job, wanted her brother, who was a healthcare professional, to do it, but we couldn't complete the power of attorney documents because the guy had lost decisional capacity. What we did instead is really carefully documented. She and their son both declined to serve as the power of attorney, and then using the newer hierarchy from the state, you have a trusted friend who's like the 7th or 8th category down the surrogate decision maker hierarchy. He was able to be designated in that capacity, and using the WSHA attestation form, he is now officially the surrogate for 180 days. And so just understanding, we did that with case management, social work, and some others. We were able to get that all completed.
That sounds really great and advanced and complex. Mimi, what's your impression of all the hospitals around the state of Washington being able to move forward with something like that?
I think a lot of hospitals have a lot of policies in place. It still comes down to the individual clinician. It really does. And there's such a variability. And that's why educational opportunities and offerings are what we need to continue to do. Because it only takes one person to start the train out of the station, and it just keeps rolling.
Well, thank you. I want to be respectful of everyone's time.
Yes, thank you.
We did go a couple minutes over, and I want to just put in, thank you again, Mimi, and whoops. Yes, we have Karen Torres coming up for the next session, and please do complete your 1-minute post session survey. And thank you all, and hope everyone has a great afternoon.